Welcome to the Health Tech Edge, the show where we explore how technology is transforming healthcare operations and outcomes. I'm Mike Moore, your host from Productive Edge. Today's episode is all about the big question we hear from healthcare leaders. How do you actually calculate the ROI of AI in healthcare? There's no shortage of hype, and how you do know if your investment's delivering value is not just a question for the sake of asking it. It really needs to demonstrate some clear results, especially with the cost pressure that healthcare organizations find themselves under. So to help us break that down, I'm joined by Adam Block. Adam is the founder and CEO of Charm Economics and Charisma Health Solutions. He brings 20 years of experience helping health plans, providers, and digital health companies model and measure ROI, not just in theory, but in practice. Adam, welcome to the Health Tech Edge.
Thanks so much for having me, Mike.
Yeah, well, it's great to have you. And this is, I think, obviously a hot topic. And I mentioned in the introduction here the cost pressure that a lot of healthcare organizations find themselves in. So first, let's learn a little bit about you and Charm and kind of what you do there. So why don't you just give your introduction, please?
Sure. I'll tell you a little bit about my background. I'm a health economist by training. I got my PhD in health economics about 15 years ago. I spent 5 years working on the Affordable Care Act, first on Capitol Hill, and then writing regulations for 3 years for CMS. Subsequent to that, I worked for health plans and hospital systems for about 5 years. During that time, it was sort of the inception of digital health. And in my role, I was frequently reviewing a lot of this digital health technology as companies were making their pitches, hoping to get to the CFOs, hoping to get a contract to the CFO's desk. And then subsequently, what I found was that a lot of these companies had great clinical models, but they did not have clear financial models. And so I started Charm Economics to build those financial models that I know the CFOs wanted to see, and then help digital health companies to share them with their potential clients.
Yeah, that's great. So clearly, I think what's interesting too is you've done the academic piece, you've done the policy piece, you've done the practical piece kind of in industry. So, and now kind of using all that experience for your clients in the work that you guys do there. So when you think about advising your clients, they come to you with different initiatives related to digital health, whether it's AI or not. Uh, there are some different categories of cost savings that we certainly look at in our work at Productive Edge. We tend to focus more on kind of the administrative, operational productivity, those kind of facets. Clinical is obviously kind of next level kind of stuff. But how do you kind of think about the buckets and cost savings and where the ROI of these projects come into it?
So you're describing the kickoff meeting that we generally have with our clients, which is that a lot of clients they are clear with the clinical arguments usually, but they are frequently not clear with what they should be showing in terms of a financial argument on why you would use their product and how it's going to save the consumer or the client money downstream. And so we do what we develop value streams, which is, well, we think that your product is going to reduce avoidable ED visits. Avoidable ED visits are very expensive. And so let's see if we can make a calculation there. Or it's going to reduce avoidable readmissions. Or it's going to reduce outpatient care. Or it's going to shift you off of some very expensive drug onto a generic or onto no medication at all. So part of our value proposition to our clients is helping digital health and AI companies realize tangible metrics where they can eventually provide savings.
Yeah, that's good. So in terms of making kind of real metrics, like in my days at Microsoft, we focused a lot on Microsoft Office and kind of productivity savings, but we always got pushback from CFOs that was kind of a loose, metric, that productivity might not count as much because you don't know that the minutes you're saving a worker are going to be actually reinvested back in the business versus, spent at the water cooler. How do you deal with that kind of argument, or is that something that you deal with in kind of the projects you do?
I have 100% had those conversations. They went exactly the same way as you described it. And what I tell my clients is that revenue is worth more than savings dollar for dollar, which means that if I can bring in $1 million in new revenue due to changes in risk adjustment or quality score bonuses or something like that, that $1 million in additional revenue is worth more to a CFO than a calculated $1 million in savings. And so you should always aim for the revenue and the reason for that is because the accounting is much clearer. The accounting for savings is very hard to find. And this is not unique to our industry. This is across health services, right? And public health, which is like, how do you account for visits that don't happen? So that is a fundamental challenge, and that is what we do. But a lot of CFOs, and I understand this perspective very clearly, are skeptical of that. Whereas when they see last year risk adjustment was, this amount of money, and this year it was 10% more, that is an amount of money that they can then justify spending on a new product.
Yeah, that makes sense. And I think that the metrics, whether we're talking about healthcare providers or healthcare payers, I'm sure that there are, it's kind of the two sides of the equation, right? You've got all the revenue cycle attributes in the provider world, where if they're bringing in more patients, more revenue, fewer denials, right? Kind of the pieces there. On the payer side, it's the medical loss ratio and kind of the impact of operational costs and those kind of things. So there's a lot of different, which is what makes it so complicated, which is why you and the firm exist, right? To kind of help advise people and structure them, because they may be doing it for the first time, especially with an AI use case where you and the team have been through this many times.
They are frequently doing it for the first time, and that is totally right. And in the same way that lots of companies hire outside counsel because there are very specialized policies that they have to deal with in order to, right, from the legal perspective, and they want a legal team that has done it over and over again. We provide that with what we call the broader skill set that we bring, which is evidence generation. So while we do these ROI models for different companies, we will take the companies to the next level and we'll advise them on it, which is, when do I need a peer-reviewed journal article? And so we can help them to get peer-reviewed journal articles when we and they think it is appropriate, because health plans and hospital systems, as each company grows, require a higher level of evidence. If they're writing a $100,000 check, the level of evidence that they need is lower than if they're writing a $3 million check for a service.
Yeah, and I think that so many of these organizations too now are kind of looking to AI as being a technology that can cause a dramatic impact, right, and cause some of those multi-million-dollar savings on kind of key workflows or key operational areas. But I have to imagine, like, while the world has kind of been transformed by AI in the last couple of years and will continue that transformation, is the ROI of an AI project that different than how you would look at other technology that preceded it?
So I don't think it's that fundamentally different. What's different, I think, is where the AI companies tend to go versus where a digital health company is going. So digital health companies are basically saying, like, we can provide you with medical services or medical adjacent services on your phone, basically, and track your performance on them to give you better clinical outcomes. AI is a little bit more operational currently and more working organizationally. And the classic example of it is the AI scribes. You probably use a digital note taker. I certainly use a digital note taker when I remember to turn it on, and who we're meeting with is okay with the recording of the meeting. However, what we have seen, and I will tell you, so I teach at New York Medical College. I was interviewing medical students for several years, and the most common position between the years 2017 and 2020 that I saw medical students having in the year prior to joining medical school was scribe. And then those jobs have just diminished dramatically because they have been taken over by AI. What you previously had was some 22-year-old furiously writing notes and trying to connect those notes and trying to provide them so that the physician did not have to write them themselves, and it was essentially acting as a physician extender. And now you have AI tools that are basically recording and not just inputting the information, meaning like the specific transcription, but they're doing analysis of the information relative to the patient's medical records, looking at gaps of care and making recommendations that physicians would and should be doing, but they're making it that much easier because they're providing their independent recommendations, and then the physician is reviewing those as well.
Yeah, which is that's really where the power comes from a lot of these use cases, right? Is kind of the things that humans who are busy and flawed, right, just by nature, humans are not perfect beings, and the things that we should be seeing, or the insights, or the memory that we should be connecting. I always think about the example of going in for my annual physical and my doctor looking at medication that I'm on and saying, "Why are you on that medication?" Or why do you have this test result in your, and well, it's because you ordered it, doctor. I don't expect him to remember, like, he's at a, one of the health systems here in Massachusetts that I see him, and I see him, once or twice a year. And so, haven't made an impression on,
If
that's
that,
okay.
if
Right.
that, I see primary care physician once every 2 to 3 years.
Yeah, and it's like the EHR software certainly has all of that information, but how it surfaces it, so when the clinician walks in the room, they can get the rundown and know who you are, what you're about, what's going on. Like, summarizing all that information is kind of really a missed opportunity. Never mind connecting the dots about things that we should be looking at, or kind of based on the conversation. And there's obviously the scribe scenario is so interesting, because there's all that little, like, the medical jargon, right? That's where these, large language models are good, but then, there have been development of these large medical models, which have more of that jargon baked into it, so they understand more of
Right.
even the shorthand that might be used in those conversations. Um,
Yeah.
when we think about use cases, yeah, go ahead if you want to go on.
Yeah, I did want to talk a little bit more about those models, the AI scribe stuff. The real value to them is that the providers love them. And what we have seen with EMR and digital health technology in the last couple of years is that getting providers to use it, they get pinged all the time with new information about patients, and it's kind of annoying to providers. This is a tool set, and I don't want to be specific to any one brand. It is a tool set that the provider groups love, because it dramatically decreases what they call as pajama time, which is the time that providers spend after hours basically writing down notes about their patients. My wife is a primary care provider, so I get see pajama time firsthand every day. I'm looking for a report that just came out from the Peterson Health Technology Institute on AI tools. And I want to flash on the screen if I can find it. But it's basically on this AI scribe technology. It came out maybe a month ago, and it goes into depth on the details of the technology, the value proposition. The report is free. The Peterson Health Technology Institute is a foundation run, and we have worked with them on digital health technology evaluations for years, and think that they provide a really valuable contribution here.
Yeah, if you want to send me the link, I'll put it in the show notes so that people can grab that, and we'll deal with that afterwards to share that piece.
Perfect.
But yeah, that sounds great. And I think the pajama time reduction, we know that there's a variety of factors that influence clinician burnout, but that is certainly one of them, right? Is that when the day should be done, the day isn't done because they have more follow-on work to do. And on our last episode, I spoke with Mike Doctor, who's a medical doctor. He's the founder of Doc Health. His company is really focused on the task management aspect. So instead of just burying all of that follow-up in the notes field on an EHR record, we'll actually extract the tasks and then put that into motion so that the tests get ordered and the follow-ups are done, and all the other kind of elements, and kind of using the automation of AI around that. So there is a tremendous opportunity to connect the dots around all of this. Can you think of another use case or two that you're seeing pop up that, from a, we talk a lot to customers about the maturity curve of kind of what they're ready for, and in the risk, all obviously, as well as kind of an element of this, like taking on a high risk use case for AI as your first project or two is probably not the best idea, right? Starting simple, low risk, something that kind of meets you where you are in the maturity spectrum is probably a good idea. But what are some of the AI use cases that you see coming around from clients right now?
So the one we've been talking about for years is radiology, because basically radiology is a visual inspection of radiological reports on whether it's a broken bone or whether it's a ligament tear, or basically, and it's viewing all sorts of imaging and making a diagnosis. I have been hearing this for the last 15, 20 years, that like radiology is going to be reduced in terms of the labor power that's needed, and AI is going to increase. We haven't seen that yet, and I'm not quite sure why. But that's something that I think we expected to see, and AI has not infiltrated that area as quickly as many people 10 or even 15 years ago potentially expected.
Yeah, that's interesting.
Yeah, so I like to paint a a full picture, not just everything like AI is taking over. It's coming for your jobs. Care management gaps is an area that we expect AI, which can scan electronic health records to identify what we have called in the health plan world as chase lists, which is basically like patients are supposed to get an eye exam if they're diabetes, and they are supposed to get a flu shot in certain situations. And right, there's a whole bunch of care that individuals that meet certain criteria are supposed to get. And AI is going to do a better job of scanning a broader set of records than is currently being scanned by the EMR technologies that are currently out there. So that's another area that I expect AI to be pushing into.
Yeah, and we're actually working with a couple of our clients on care gap programs with AI right now, where it's doing what exactly kind of seeing what's actually happening, mapping back to what should be happening, surfacing that in front of the care teams, and then automating the steps to do the follow-up, the outreach, the patient education, the appointment scheduling, those kind of pieces to kind of put it in motion, which is really where it's exciting. So, surfacing insights, interesting, creating action from it, and then obviously seeing the improvement in patients' health, right? So that's kind of the big piece, is that we know like a lot of the financial incentives here in the US healthcare system are about identifying care gaps and inviting people into programs. Whether or not they actually participate in the programs, improve their health outcomes, those kind of things is kind of not part of the calculus right now, but coming soon. One conversation that you and I had in the past, we talked about prior authorization. And now,
Yes.
as we record this here on the last day of June in 2025, a week ago, HHS and CMS came out with a new set of recommendations or rules, I guess, that they're going to put in place for prior authorization, and kind of updating some of the deadlines around 2026 and 2027 for some more automation around this. But I like your take on this, of kind of this, I think the way you described it, if I remember correct, is kind of like an arms race around
Arms
payers
race,
versus
yes, that's a
providers.
term.
So
That is the best, I think, analogy to what has been happening. And this has been, and I worked on the health plan side, and then I worked on the hospital side. So I saw both sides of the arms race about 10 years ago. And what you see happening is that health plans' job, and this is what they have been. I'm not just saying private for-profit companies. I'm saying like health plans mandate from Medicare. Health plans mandate from Medicaid when they are private Medicaid and Medicare programs, is that they are supposed to reduce utilization for unnecessary utilization. And the way that they have gone about doing that universally, at least in the United States, is through prior authorization. Providers will tell you that prior authorization is the bane of their existence, because they have to put up a whole bunch of criteria, and it could be showing diagnostic tests, and creates a huge paperwork burden for them. And health plans will say, well, if you don't meet that paperwork burden, then you didn't really need this procedure. You just sort of wanted the procedure. And so what we see now with the automation is that plans are rejecting if you don't have all these criteria met. And the hospitals or provider groups are basically expanding what they can do internally without having armies of people in finance who are doing it by hand. They can identify, using more of an algorithm, the requirements from each different unique health plan. And when I say health plan, I do not mean each different health insurance company. I mean the individual level plan within the company often has different criteria. And so as the technology gets better, they can go up against each other to basically try to get the same claims paid. But at the end of the day, all the investment that goes towards these services on both sides are not going towards patient care. This is just towards one side getting paid or the other side not getting paid.
Yeah, it's mind-boggling. In fact, I learned about another company, another AI company, kind of health tech startup uh, called Outbound AI, and it it's as it sounds, kind of it's a telephony-based kind of generative AI solution, but essentially has the AI call agents who work for the provider calling to the payer, calling their 800 numbers to request things like an explanation of benefits
Mm-hmm.
to be faxed to them for, Mike Moore, who saw, Dr. X on this date for a billing amount of this. And, as someone who's been in the technology industry for 30 years, I said, like, isn't there a better way to get that information? Like, isn't there an API or EDI or something like that that you can do to get that information? And when I talked to their CEO there, he explained, no, they make it difficult. They could, in theory, modernize their operations on the payer side to make that information available digitally. So you could
Yeah.
call an API or a web service or something to get that, but it's not the reality of how things operate in the industry. So creating AI to then have an agent call a human, in theory it's a human, maybe it's another AI agent. You've got AI agents talking to AI agents, having a voice conversation to then request a file that then gets faxed over, that then is consumed digitally. I mean, like, it's mind-boggling, right? Like, you wish you could just kind of wipe the whiteboard clean and start over with a lot of this, but that's obviously not the reality of the tech
Well, because
industry.
each side has the incentive to ramp up their technology, which is exactly why I call this an arms race. And it's a good comparison because, like, at the end of the day, none of all of this investment is being used towards patient care. In the same way with many arms races, like the actual, buildup of the arms aren't actually being deployed. It's just to show that you got it.
Right. Yeah. Mind-boggling. So let's pivot and talk about the good AI projects and kind of measuring the outcome, and really thinking about some of the key metrics. And I know you speak about quantifiable outcomes. So can you kind of give us your take on that and what healthcare leaders should be looking for in terms of how they measure the impact of some of these projects?
Yes. So in terms of clinical care, you need to be measuring some of the easiest to measure outcomes. I think that's the clearest. Anytime you're measuring like a spillover effect or something that's a secondary effect, it's very easy to lose the signal. And so the classic metrics that are measured are care gaps, meaning are the patients getting the flu shots that they're supposed to be getting? Are they getting all of the diagnostic tests that they're supposed to be getting if they're diabetics? And I think avoidable ED visits is just another classic one that is, should be measured. But it really depends on what the specific technology is. So, if we do a case, it's hard to broadly generalize what that should be. It's very technology specific, but that's one that we use pretty consistently.
Yeah, so I think that's great advice, kind of focusing on the primary impact versus the secondary effect. If you can capture and measure the secondary effect of the things that you're doing, then that's great. But yeah, having something, whether it's around the administrative savings, the medical savings, the productivity gains, whatever those kind of key categories are, and then kind of double clicking into that, because I think that so many organizations that we talk to, they're under a mandate to reduce or eliminate spending on
Yeah.
technology initiatives, but they're also under intense pressure to cut costs. So if you actually said, well, we're going to raise a business case for this AI project, which is going to help us save this amount of money, maybe have a 10 or 20 or greater, to 1 ROI on the project, you really have to be somewhat bulletproof as you go in and present that ROI case.
Oh, I love the word bulletproof. We talk about, we use that word in some of our models because, we say that they're bulletproof frequently when we say, okay, well, we got the epidemiology data from the CDC. We got the, average healthcare spending from, ASPE or ARC or some HHS agency. And then we got, the estimate of the intervention impact from a Journal of the American Medical Association article. And usually when we have those three things is that we use the term bulletproof for our models. I think that is a good way. I think that's a good way to think about it.
Yeah, and I think that that's, the hard part obviously is getting started with a lot of these initiatives and really trying to put the measures to it. So, kind of
Well,
using that as
one thing I
yeah,
want to add, if I
yeah,
can,
of
Mike,
course.
is that I think it's very important to have a very tangible metric. The more tangible metric you have, the better. So in terms of productivity, like you said, Microsoft isn't going to necessarily believe that the minutes you generate are resulting in minutes for the company. However, in healthcare, productivity, at least for many providers, is measured in RVUs. That is very measurable. And I think that CFOs would see that differential and respond to it. It is measured in hospital in terms of average length of stay. If they see on a daily CFO briefing that the average length of stay has reduced from 4.9 and consistently is now down to 4.6, that is very tangible. So you have to find a tangible, believable metric. And if I am a new company, I want to have in my head, what is that metric? And if it's sort of like, we call it the hand waving, if it's very hand wavy and you can't point to a specific metric, you need to rethink your business model to point to a specific metric.
Yeah, and we love it when when we do our projects at Productive Edge, when the customer already has that ROI set of goals established, and we can actually build out the dashboard for it as part of our project, right? So, if there's an existing kind of data warehouse or data initiative where they can plug it in as a metric, add it to the dashboard, or if we have to create something, either way, we want to measure, we want to track that, we want to see the impact of the work that we do with our clients and see them realize that, because we know that's what will fuel future initiatives of transformation as well, which is what we're all trying to do, right? Is kind of make the industry as a whole operate better.
Absolutely. If they walk in the door and they know what it is, then that's great. I will say that, part of our value proposition as a company is we take companies that are, and maybe they're a little bit more early stage, that don't know. They have a clinical idea and they know it. It's good at what's going to move the metric clinically for a patient, but they don't necessarily know from a financial perspective, and we can help them direct towards something that is going to be, a metric that is measurable.
Yeah, that makes a lot of sense. So as we get ready to close here, what are some of your top 2 or 3 pieces of advice for healthcare executives when they're thinking about where to invest in AI or how to measure success?
So, we do use ROI. I think it is a very easy to calculate metric, and I think it is very useful. And I think you have to estimate it looking at tangible metrics, whether it's an increase in RVUs or whether it's a decrease in avoidable readmissions. You have to find some tangible metrics that are consistently used in the industry. In other words, don't make up your own.
Yeah, that's great advice. So if
That's
folks want to connect with,
yeah.
yeah, go ahead.
No, that was my primary, and then the only other thing is that as you're selling to health plans or hospital systems or provider groups, as you get bigger as a company and your technology expands, the evidence standard is going to increase. So just because you got a pilot from a couple of slides and a back of the envelope calculation, as you get your third or fourth pilot, the evidentiary requirements from these companies is going to expand. And as you go and you scale to being 4 clients to hopefully, in a year or two, 15 to 20 clients, then you're probably getting in the realm where you're going to have to be, presenting at conferences and doing peer-reviewed journal articles.
Yeah, and I think what's key is obviously customers on the payer and provider side deal with a lot of different vendors who are going to make all kinds of promises, and hopefully they show up with information. They've partnered with your company or someone like you, right, to kind of do a true study and really measure
Hopefully
the
our
metrics and
company.
economics. Yeah, of course, no bias, of course, there, but hopefully they, it's a lot of vendors. Obviously, they have kind of a built-in bias for their solution and why they think they're the best. Having some sort of a third-party study or model that goes with it to help measure the economic impact of this investment, that a customer can kind of look at and use, and it is bulletproof, certainly adds a lot of confidence to them, because this is the area where, they're putting their jobs on the line, especially if they're raising this in kind of this climate of, like, hey, I think we can save millions here. or I think we can earn millions more, by acquiring new patients, or kind of whatever the strategy is. Everybody needs to really kind of have their business case buttoned up, and I think that taking this kind of view and working with experts in the field is really key. So
Yeah, I think there is some value to external analysis. And as we say to most of our clients, our goal is for you to do your demo when you're presenting towards the CEO or CFO, and then just include something related to cost savings or ROI in 1 or 2 slides. And if that goes over well and they believe it, then the onus is on you to have a good clinical case. And that's really where most of our clients and most of the folks that are generating new technologies, that's where they want to be. They don't want to be spending too much of their time on the financial portion, but if they don't spend any time on it, it's very hard to win new clients.
yeah, that would be kind of a red flag. So yeah, good that everybody is kind of realizing they need to come to the table with something to at least give customers something to react to. So super. Well, this has been great. Adam, learned a lot from this conversation and got some great advice, and especially kind of your wisdom around what you're seeing happen in the market and where people are getting value from these solutions, especially as a lot of health tech vendors work with you and the team to figure out where they can make an impact. And ultimately, what we all want to do is really help advance U.S. healthcare, transform the industry, leverage this great technology to improve care, reduce the cost of care, improve access, all the outcomes that we're all trying to drive. So I know that folks can connect with you on LinkedIn if you want to connect with Adam. There's also charmeconomics.com where you can go and learn more about the firm and the work that they're doing. But Adam, I just want to say thanks for joining us today and sharing all of your insights.
Thanks so much for having me, Mike. It's always a pleasure to chat about new technologies that are coming out and evaluating their efficacy.
Yeah, that's great. And thanks for everybody for listening to the Health Tech Edge today. If you enjoyed the conversation, please subscribe and share the episode. We'll be back soon with more real-world perspectives on how technology is shaping the future of healthcare.